Okay, let's see. Okay, can you see my window?
Yes, we can.
Okay, I just have a few cases this week. This first case is a patient with history of aortic stenosis, of course, who had a transcatheter aortic valve implantation here, and we can see the scaffolding of the sapien valve here in aortic position. And we're doing more and more as part of the protocol post-TAVI studies, gated CT of valves after they're put in, anytime from 1 to 2 months after they're put in. And we looked for thickening of the leaflets, any evidence of thrombus along the leaflets. And of course, in the longer term setting, you'd expect to see eventually degeneration of the valve and leaflet thickening and degeneration. But I'm showing you a patient who had a valve put in about 2 months prior to this study. And I'll show you I'm scrolling through and you can already see that these valve leaflets are really not thin like we'd expect. They're quite thickened here. And I'll actually play the axial series here, and you can see that here are the valve bioprosthetic leaflets that are very thickened, and in particular, this one is not moving at the base as much as you'd expect. Let's reslice that and show another view through the valve. And you can see that this is a very abnormal valve with leaflet thickening and restricted mobility, particularly at the base here. So haven't had a lot of experience with post-TAVI cases, but we've had over the last few weeks at least a couple of cases of valve leaflet thrombi, and presumably this is another case of thrombi, and this one's fairly dramatic because you can see that all of the leaflets are thickened and presumably affected with thrombus. You wonder if this was valve degeneration in the long-term follow-up period, but this patient was only given a valve about 2 months prior to this, so you can see that restricted mobility right there. So I think as we do more and more of these post-TAVI coronary cases or gated cases, we're going to see more of this. So I just thought that was a dramatic case of TAVI leaflet thrombus there.
So Brent, what do they do with these if the valve is like in this case?
Well, it's unclear. Some are trying anticoagulation to see what's going to happen. I presume that in this particular case, we're going to get follow-up to see if this decreases with treatment. But the treatment so far is unclear because we don't have. I think no one really has much experience with doing these gated studies. Soon after TAVI, and of course, echo can be problematic because you can't see the leaflets very well, and so most of these cases are referred for gated CT because theoretically you should be able to see the leaflets better than echo. So
there was a New England Journal article on this talking about the incidence of thrombus, and it's associated with a missized valves or missized apparatus. So there's a study came out last year, something that looked at a very high incidence of this occurring, and they associated it with they said it occurred mostly in their patients where they were like between valve sizes and chose that's what they came up with, that it was a missized valve. But there is some data on this, and it's unfortunately more common than we think.
yeah, I suspect it is more. I mean, we've seen over the last just few weeks at least a few cases, at least a couple of cases here. So I'll have to go back and look at that article. So okay, here's another case. Can you see my screen?
No, not yet.
Okay, let me let's see.
Hit the little play button where it's up under your control panel for your go-to-meeting.
Let's see.
There we go.
Okay, you're seeing this now?
Yes.
Okay, so here was an interesting MR case that was Called by the technologist to kind of problem solve this case. This is a relatively young patient who had some increasing, over the last few months, some increasing shortness of breath. And in doing the MR, the technologist realized that there was something here abnormal in the right atrium. And I'll show some more images of this. Let me show you a stack, a Cine stack here, and you can see what looks like a mass here in the right atrium. Funny thing about this is that it kind of becomes more and less distinct as you scroll through the stack here, this 4-chamber stack. And let me show you a couple other images here. In some of the views, we don't really see that well-defined filling defect at all. We see what looks like this linear jet. And I'll tell you as well that we don't know that much about this patient, but referred from outside with shortness of breath, of course, and the indication was anomalous pulmonary vein. And I don't have the outset echo, but I presume that an echo was done showing some abnormal flow close to the right atrial SVC junction, where an anomalous vein from the right upper lobe may drain. And I'll show you some more images from, sagittal Cine stack here. You can see that filling defect there. Here it is again. Let me show you some other images, though, here. And you're starting to see that there's some abnormal flow here into the atrium. And I'll try to get a view through the abnormality here. And as we're looking at other portions of the stack, you can see there's an abnormal vessel here that comes in and out of the field of view. I'll show you another image here. Here's an abnormal vessel that comes in and out of the field of view. You can see it here. Once you see it again, here it is. And here you can see that it's actually coming off of the aorta. So it's winding around there, a very abnormal vessel there. And I'm going to go to some of the some of the flow stack here, the phase contrast, and you can see there's abnormal flow in this whole area, and it's going in 2 different directions at once as we're scrolling through the stack, the phase contrast stack. Let's see a little bit more of that. You see that abnormal flow in that region there. And let me just cut to the coronary MRA here, and let me show you that scrolling down from the aortic root, you can see that there's an abnormal, very abnormal proximal RCA there, and we'll follow that around. There's a huge vessel that's coming off there, and it's winding around here, and goes back, comes back down, and then drains into the right atrium. So this is a big fistula, presumably from the SA nodal branch coming off of the RCA that is causing all of that artifact there right in this location. There's no mass there, but just a big RCA SA nodal branch fistula draining into the right atrium. You can, of course, see that the right atrium is enlarged, the right heart is enlarged in general, and this is presumably the cause of the abnormality on the on outside echo that they saw that they thought was an anomalous pulmonary vein. And you can see the pulmonary vein drains normally from the upper lobe into the left atrium. So I just thought that was a really nice case of artifact being caused by this large fistula.
That's nice. So I'm still confused on why your SSFPs, why if there's good flow in that vessel, it appears as a dark lesion. Can you see on the initial SSFPs? I'm a little confused by that, but it's okay. It's fine.
I was hoping that someone had some other ideas about that, because I think that the flow is just in the right direction to cause that artifact. So you can.
Yeah, I mean, on the phase contrast, I understand it. It's just it's odd on the because theoretically on SSFPs, flowing blood should really stay right, but I don't know much about how if it's I just. Anyways, it's interesting. Great case.
I think it's a strange phenomenon where you have some really strange turbulent flow there, and it's just in the right axis to cause that. So don't quite understand the physics of that myself there. But very nice, interesting kind of two-directional flow here, and in different directions through the plane that we're imaging here. Okay, and let me show you. Here's another cardiac case that I thought was really nice that my boss showed me. And this is a 14-year-old patient, actually, who came in. This is a coronary CT that we did. And first thing you can see at the RCA here, and you can see this abnormality of the RCA, very strange abnormal proximal RCA. I'll point out that the this branch, the conus branch here, is pretty dilated. You can see it coming across here, so that's abnormal. And then following the RCA on down, you can see some alternating areas of enlargement and narrowing of the RCA, and we're going to come across down here. You can see just really tortuous RCA, a large acute marginal branch that's shooting across toward the left. And let's back up here to see why that is the case, why those collaterals are present. Here's the left main, of course, and you can see that here's the LAD, and that's completely occluded. Here's the circ, the proximal circ, and here's the proximal circ. Here is a large obtuse marginal that's branching early that you can see. And here's the circ here, and you can see that the circ eventually occludes right there. And after that occludes, we have some reconstitution of the more distal circ, and here is an aneurysm, peripheral thrombus. So diagnosis is not confirmed yet, but presumably this is a case of Kawasaki disease in this 14-year-old, causing some really abnormal coronaries with occlusions and aneurysms and stenoses. So I just thought that was an interesting appearance. I mean, the proximal RCA was so abnormal that at first it was thought that could there be a fistula here to the right atrium, but on cath that was not really borne out. Just very irregular RCA there. That was presumably due to, some occlusion of an aneurysm that may have partially recanalized. But I just thought this is a nice case, presumably of Kawasaki disease in this 14-year-old.
Yeah, it's nice.
And then one more. This is the most exciting one. Let me show you the chest CT first. This is a relatively young patient who came in actually with an arrest, and this is a chest CT that was done in the process of the workup. And I'll withhold some history and just for just a few minutes, a couple minutes from now. You can see that there are these peripheral areas of ground glass opacity, some peripheral nodules here, clustered nodularity, and a lot of ground glass. And in itself, this is of course very non-specific. But let me show you, and I'll show you the pulmonary artery as well. The pulmonary artery is a little bit on the larger side. But let me show you. Here, look at that very fulminant.
What is
Helicopter.
who are those?
Hello?
Yeah, no, it's a very common look to it. It's interesting that when they have these little I'm assuming microemboli, that they all look very similar with this kind of peripheral ground glass nodular stuff. Yeah, that's a nice case.
Hey, Brent, was there right heart failure?
I don't know. I don't remember the echo, but you can see that there was some straightening of the septum, and I was showing the pulmonary artery was a little bit on the larger side. So, presumably we are seeing some right heart, some elevated right heart pressures here. Septum certainly abnormal. The right atrium's enlarged, and she did present with an arrest. So, not sure I remember the echo findings, but certainly we see some right heart evidence of right heart strain here.
Is there a little bit of air in the mediastinum and/or vessels anterior?
Let's see. I don't. This, I believe, was within within lung. I believe. Was that what you were looking at, Howard, or
Just lung? Okay.
kind of spared lung? I think around the. Anyway, those are my cases this week.
All right, thank you, Brent.
Very nice.
Who'd like to go
Very nice, thank
next?
you.
I got some cases I can show.
All righty.
All right, so this is a guy with connective tissue disease, scleroderma. This is going to follow a little bit of a trend I'll show on another case. So this is a guy who has diffuse parenchymal lung disease. I think it's pretty classic for NSIP, but whenever I see this degree of ground glass associated with it, and I always think that's pretty much, in most instances, some superimposed areas of organizing pneumonia. And sure enough, this guy underwent open lung biopsy, which showed NSIP with organizing pneumonia. Then he progresses, and this is a few months later, develops more consolidation. Actually, so here he was here. Here he developed more consolidation. This is when he was biopsied and had NSIP with organizing pneumonia on biopsy. And then what's just fascinating to me is how these progress over time. And then eventually he has, a lot of the ground glass is still there, but it's predominantly resolved, at least a lot of the more dense ground glass, even bordering on consolidation. And we're just left with this severely fibrotic process, and he undergoes lung transplant. And the final pathology on lung transplant is, severely fibrotic NSIP with areas of organizing pneumonia. So again, I'm a full believer in that in a lot of these cases of NSIP that, the initial injury is secondary to organizing pneumonia, which then due to repeated injury, and I have about 7 CTs on this guy showing it progress over time. These I'm just showing you guys a few, progressing to fulminant NSIP. And again, now I have path on 2 sides on this case. And following
a period of years, Seth, or many months?
No, so this is pretty quick. This was 3 years. So, they talk about NSIP, it's got a good survival, but the survival is based on, as you guys all know, degree of fibrosis. And severely fibrotic NSIP it's not as bad as UIP or IPF, but it has a pretty poor survival unless the patient goes explant. So here the first case was September 2013, and he was at fulminant fibrosis, in 2015 and got his transplant finally in early 2016. So relatively rapid. And the biopsy, the explant was just classic severely fibrotic NSIP. And then show you, and again, I have more cases, more images than those. And then to reinforce that point of, let's see if I can get this to work with me and not be a pain in the butt. Let's look this, here, this, and here, this, and we'll do the same thing, and we'll look at another case and see how this one goes. So here is a young patient, also with a connective tissue disease, so let me get our dates correct. Here's 2000. So here's the first case in 2013, and going the wrong way. Sorry. And she has a history of rheumatoid arthritis. And, we know rheumatoid arthritis is associated with organizing pneumonia as well as usual interstitial pneumonia. but I think anyone would be hard-pressed not to look at this and say it's a gorgeous example of organizing pneumonia, which it was because she underwent biopsy. This is her pneumo in her chest tube post-biopsy. You can see a thing. And the biopsy, so they treated her with high-dose steroids. We can see that some of the peripheral consolidation is melting away, but we still have this diffuse ground glass. This is only a few weeks later. Biopsy shows organizing pneumonia, and just to show the progression of this, so they treat her with high-dose steroids, and then it wasn't working that well, so they added CellCept, and it's getting a little better. But then I'll go to the final study showing, this diffuse pattern of fibrosis, which is, and I have another study I'm trying to get from 2015, which shows that it's even worse. And she kind of has this organizing pneumonia, fibrosis, whatever you want to call it, NSIP with organizing pneumonia. I mean, to me, this is more just organizing pneumonia that's kind of progressing to some degree of fibrosis, not really. Well, whenever they see the fibrosis with this, it usually is NSIP. But anyways, it's just very interesting to see how some of these progress over time. And we now have a large number of these cases of organizing pneumonia, sometimes cryptogenic, but most commonly due to some systemic inflammatory process leading to kind of this diffuse fibrotic process. We've got now about 10 that have path. This one doesn't have path on both sides. She only has path early on, which showed OP. And if she goes to transplant, maybe we'll get the second level of path. But what we've seen is this over and over again. And organizing pneumonia, classic OP, fibrosing over many years, and then turning into NSIP with areas of organizing pneumonia. And I'll leave it up to you whether you believe that they're related. I think they're causative, but that's quite debatable. Not to me, but clearly out there to other people, it's quite debatable. Now, this is just a nice case that we had yesterday or 2 days ago of a woman who has aortic stenosis who is undergoing surgery for her aortic valve soon, and they noticed that her pulmonic valve was kind of strange looking and her pulmonary arteries enlarged. And you can see this woman has a bicuspid pulmonary valve with fusion of so this is the left, this is anterior, this is right. So if there's fusion, so this is like a little fused raphe down here between the anterior and the right, and forming a nice bicuspid valve. And what I'll show here is that her main PA is quite large, but it's really not that pattern that we see in stenosis. The whole thing is kind of large. The right is not small. The main is obviously quite large. The left is big, and some of it may be due to the flow, but it really isn't. The valve plane is by no means stenotic. It's about 3.5 centimeters. But she has this very large ascending aorta, this very large pulmonary artery that you can see here. And so it's just interesting. She has no other congenital heart disease. She has no other issues except she does have aortic stenosis, which is a trileaflet aortic valve, but has this very large main PA and a bicuspid aortic valve. And it's most commonly associated with congenital heart disease, but this woman, it was really, really de novo. So that was just kind of an interesting case. We see, but
she didn't have pulmonary regurg, did she? It was just
no, but she didn't have stenosis. That was the thing.
And,
I mean,
bicuspid, but not stenotic.
Not stenotic. Her velocities were not elevated. She had no regurg. Her max velocity was actually only about 140 centimeters per second, and they got a very similar number on echo. The by planimetry was nowhere near being stenotic, but and this is her aortic valve, which is more severely stenotic. So they were going to have to go in and replace her aortic valve, and they were wondering what to do with her pulmonary artery. And I think they're thinking about replacing it as well, given her main PA, although I don't know if that will help or not. So those are Yeah, I mean those. It's just interesting. I haven't seen. It almost looks morphinoid. It looks like an annular aortic ectasia, but it's on the PA. But she doesn't have any history of that, and I looked it up and never saw anything in relation with Marfan's with pulmonary valve issues. But interesting case.
Maybe she's got syphilis over her.
Yeah, maybe she's got PA syphilis. In this population, it's possible. You never know.
Okay.
Those are my cases, Jeff.
Thank you. All right, who's next? Howard?
I can show, I've got one or two that are interesting. This is a kind of an interesting, I'll show you the bronch in a moment, which you will like. So here is the person at time X when he wasn't as healthy as he was on the left side. So that's for comparison from before. So it's a nice teaching case for an opaque hemithorax, trying to differentiate perhaps between pleural fluid, lung atelectasis, or perhaps a combination of the two. There's some aeration of the left upper lobe a little bit. So here is the CT that goes along with that. Let me see the time here. It's the same time, just a few hours later. So here you can see that the airless lung, pretty much 99% airless, is kind of small. A little bit of air down there, but not much else. Let's look at the airways and see how far we get. Down the left main, which is going to peter out pretty soon right there. And then looking at it right there and trying to discern the presence of an obstructing lesion like a mass or extrinsic. Not really. It just tails off into nothing. And then, of course, the question is what is sitting right in there producing this atelectatic lung? And the answer to that is right here. And to bring that up a little bit, there's the description, and they actually labeled it almond. So there was a nut there that was aspirated. It broke up into pieces when they took it out, as you can see there. So that's aspirated nuts. So I don't know if you're watching TV or the Olympic Games or something, but there's the nut right there. So kind of a nice bronchoscopy correlation there with that right there. All right. This one is really nice. So this came in on the weekend. I'll put the frontal up and the lateral for you alongside each other and take a look at that at the basal right hemithorax. And you'll see that it's quite opaque, but let me change the window width a little bit. As you do this, you see that it's very opaque. And bringing up the lateral again, you can kind of see the borders of this or where it is. So this is very opaque in that basal right pleural space. The reason for that is here. So sorry about that. So there you have it. So there's a lot of pleural membrane calcifications on both sides, but right greater than left. There's quite a bit of subcostal fat, but that clearly is very attenuating. So milk of calcium in the pleural space, in that portion of the pleural space. And I don't think I'd ever seen that before. So I started looking around. You can find case reports of, in a chronic pleural space, fat fluid levels and fat milk of calcium levels. Now, he does not have fat to form that, but that's attributed to chronic pleurisy. There are mentions of chronic tuberculous pleurisy. The notion of the fat, which he doesn't have, is pseudocardiothorax, so it's thought maybe to represent fat from degenerated cells in the fluid, but a really nice example of a milk of calcium basal pleural space. And I don't know that he was symptomatic from this. He's getting worked up for cardiac disease, but it's a really nice radiograph. And I've not seen that before myself. Has anyone seen that or other cases like it, or have any other ideas other than calling it milk of calcium?
No.
No, I've seen one with that it was just filled with air, but it had diffuse pleural thickness. It looks like he has asbestos plaques on the other side.
Yeah. Yeah, I don't know if it's asbestos related or pleural
Can you
calcification from
scroll up to the
nut.
top? Let's look at the top left and see if there's anything anteriorly on the left pleural in the way of plaque. Not really. Huh.
No, I don't see any plaques elsewhere. It's quite extensive here, but
And is there atelectasis in that left lung base associated with this pleural calcification, or is it the lung? It's a little atelectatic near it, isn't it?
I presume, I don't know, really know what's in that little patch of parenchyma on the right side.
But David,
not
would you
like-
agree those are pleural asbestos plaques on the left hemidiaphragm and posterior there on that image?
I would vote they were too. Just that position's pretty good.
Especially on the diaphragm. But I've
Yeah.
seen asbestos cause what Howard's showing, and you can actually see the kind of almost like it's trying to be a fluid level there. You got a little denser stuff. That's impressive.
Yeah.
So that was a surprise. I encouraged the surgeon not to do anything about that. I think they actually tried to tap the fluid and only got a little bit out, and perhaps it's hard to get a needle through that. And maybe this is really thick stuff, not easy to come out of a small needle, perhaps. So perhaps not surprising they didn't get much out of that pleural fluid. But I'm not even sure they should have done that because, as best I could tell from the notes, he probably wasn't symptomatic from this, even though it's pretty impressive. Okay. This is kind of case we've all seen before. So the radiograph is really just a bedside radiograph. It's going to be very hard to see this. So let me just show you the tracheal lesion. And it's rather large and rather disturbing. So here's a relatively young person with this very nasty looking tracheal lesion. It narrows the lumen. It's near circumferential, but it's pretty bulky. Anteriorly, it encroaches on the lumen right there. And usually when I see this, I usually think of adenoid cystic carcinoma as my first on my list for primary tracheal tumors. But of course, there are the others, the squamous and the mucoepidermoid as well, on the top of that list. And this one turns out to be a squamous cell cancer. Really looks nasty, as you can see there. So they're trying to decide what to do about that, how to resect that. Is it a long length? Can they resect that and still do an anastomosis? So that's up in the air. But pretty unfortunate person with a really bad squamous cell tumor in this case for that tracheal lesion. And let's see what this one is. Okay, this is just a nice example of a person without a right-sided SVC. Now, I know I wouldn't diagnose this. Lev kindly showed this one to me, but after you've seen the MRI, which I'll show you, it kind of explains why there isn't any shadow here that looks like an SVC in this location. So here is some images from the MR showing you a nice, let me just bring up the coronal, say, a nice absent or right SVC and nothing there. And here's the one on the left side, right there. So just a nice congenital absent right SVC and a left SVC that does drain into the coronary sinus appropriately, like that. Just a nice example of that. Sorry about that. Okay, Jeff, those are my cases.
Can you see the left SVC on the radiograph in retrospect?
Gosh, I could not.
Okay.
No,
No.
can't see any hint of it. It's just plastered over there.
Okay. Cool. Travis?
Now we kind of know why this looks the way it does, sort of, because that SVC is not there.
Travis or David?
Alrighty,
All right.
those are mine.
All right. Well, Travis or David, do you have cases? I don't hear. Okay, well, I'll show some for a minute.
Jeff, are you there?
Yeah, here I can show some real quickly. Let's see. Well, I've got a companion case to go with Howard's case. Hold on. Let me get this loaded up here. And oops, it's too big.
It should be coming up.
Yeah, let's see. Show my screen.
Good.
All right, now you see a CT scan?
Yep.
All right, so this is a young patient who also has an airway lesion here, sort of in the lower neck, upper mediastinum. You can see a lot of it is extrinsic to the trachea, pushing on the lumen. It's a nice smooth interface here. So they did put it a little bit protruding in here. They did a scope and biopsy this, and actually you see there's this necrotic looking mass in the anterior mediastinum. So this ended up being a Hodgkin lymphoma. So presumably a neck node that extended directly in. So, young patients, as you said, Howard, adenoid cystics, they tend to be localized early on. But I have seen a couple cases of lymphoma involving the trachea. It's probably through direct extension. This lesion here looks like a rising in thymic area, would probably make you think of either metastases or lymphoma. But another young patient with an abnormal airway mass. I'll show you the radiograph. Oh. Looks like a thyroid goiter on the radiograph.
Yeah.
Okay. Go ahead.
No, that's fine.
Okay. Okay. This is a pretty scary case. So this patient came to our hospital with a GI bleed. And we had a diagnosis at the time, but had an aortic dissection repair about just under a year and a half ago, and came in with a GI bleed. So this is the CT from the outside hospital. And you can see there is gas here in the mediastinum. There's all this soft tissue and fluid. This is the material on the graft here that's wrapped around the repair. And you see all these abnormal contours and all this loose contrast spilling in the mediastinum. There's some atelectatic lung. And you'll follow the esophagus down here. It's full of fluid. It's dense fluid, about 30 Hounsfield units. Goes all the way down to the stomach. And you see this high attenuation material in the stomach. So this is an aortoesophageal fistula related to this infected graft repair here. So obviously these are really bad. This patient was not taken in the operating room, was just actually coded here, and then they decided not to. After they resuscitated the patient, they decided to go to comfort care. But these are pretty bad. One of the rare complications of these things. So given the surgery had been a year ago, presumably the graft got infected somehow, got seeded, and just sort of broke down in here. And the gas presumably is coming from the
Jeff, has it created a fistula to the left upper lobe as well, or is that just infection?
I think that may just be infection, or if she aspirated when she coded or what. I don't know. I don't see contrast going into the upper lobe. I don't see a vessel coming off of it. It looks like, and there's nothing in the pleural space, so it looks like the pleura is probably intact. But that's a good point, because I know we can sometimes see that. Interesting that the I'm not sure why the brachiocephalic is occluded there, but probably just being squeezed. All right, so that was bad. Here's another. This is not a chest case, but it's a vascular case that one of the cardiovascular fellows showed me from the weekend. So this is this is a younger patient, known vasculopath.
We don't see your screen yet, Jeff.
Sorry.
What?
It worked last week. Okay, there we go. So now you should see a CT.
Thank you.
So watch the aorta go down. So as we go down, you can see that it's got a very small lumen, and here there's hardly any contrast, and there it's occluded. So this is a Lariche syndrome, but this is a beautiful case because you'll notice all these collaterals in the body wall. And as I go down, you can see them all. Really pretty, and you'll see that the pelvic arteries will reconstitute distally. She actually had great 3-vessel runoff, but we got all these pelvic collaterals. So this is a Lariche syndrome, an aortoiliac occlusion. You see the left external iliacs reconstituted. Now you got both the common femorals and the superficial and deep femorals are widely patent there. She also may have what's called nutcracker syndrome, something I had remembered vaguely but couldn't remember all the details about. Her superior mesenteric artery comes off at a pretty steep angle right off the aorta, and the left renal vein crosses right here, and you can see it's compressed. This can cause intermittent hematuria, can cause pain, ischemia to the kidney. So, and it often has to do with exercise and positioning. But we don't have any actually dynamic images on this, but this is a presumed, or at least a possible nutcracker syndrome, where the SMA and the aorta compress the left renal vein. So I actually included with the case a nice little article I'd found, which you may not see yet. There we go. On the nutcracker phenomenon in this, if you want to read about it. But they showed compression there. Okay.
And in this, Jeff, is it what is the etiology? Is it thrombosis, Leriche syndrome? I forget.
Yeah, it's just bad atherosclerosis of the aorta. And just, I like the case because the collaterals were quite impressive. Let me see. I'll show one more for time. Let me show this one because it's something we don't see a lot of. So this is a woman who was referred to one of our, I'm going to show you just a second here, was referred to one of our pulmonologists for lung masses. Now she's pretty much asymptomatic. You can see there's at least 2 masses, maybe 3 or 4 here. The lateral projection shows these well-defined masses in her lungs. This is her
She's got a little area in the esophagus.
Yes, and here's her CT scan. And you'll see there are these very well-defined consolidated masses with some ground glass on the periphery, patent airways that go right through them. So the masses are very much in a peribronchial distribution, very well-defined, sharp margins. So, you think of things like organizing pneumonia, infection, but again, she's asymptomatic. And one of the other things I like to think about when I see these things with air bronchograms and they sort of fade but have still very distinct margins is pulmonary lymphoma. So I told him it was lymphoma, and then 2 of my colleagues at different points in time when different people have been involved also said lymphoma. They did a core needle biopsy here, didn't get anything. They actually VATS this, and for some reason, I guess they were unable to establish a firm diagnosis, showed some atypical lymphocytes. And for insurance reasons, the patient had to go go back to a different healthcare system. And we just got the path back. So I don't know what happened, what they did, but I presume they either did another core or another VATS. And this is lymphoma. It's primary pulmonary lymphoma. I don't know the type, but I'm going to presume this is a maltoma. I had some serial images. It hadn't changed in several months. So a Burkitt lymphoma or a diffuse large B cell would progress. So this is probably multicentric malt lymphoma, low grade, asymptomatic. But very characteristic appearance. I always put it in my differential of chronic consolidation. And we were trying to explain to pulmonologists why we all came up with a conclusion. There's a certain look to it. And I think this is pretty typical of it with these just very sharp margins and absolute preservation of the airway. Okay. So
and the stomach looked okay on the CT?
Yeah.
Sometimes they also have a gastric lymphoma.
Right.
Time will be more, but that looked okay there.
Yeah, no B cell whatsoever.
Yeah.
Depending on these, sometimes I've seen some of these patients where they just observe them. There's no treatment because it's so low grade. I think it's waiting for the full type to decide what to do with her. I don't know if she'll come back here or not, but so I may not get any further information. But it is confirmed. We did get the diagnosis from the outside physician that this is indeed lymphoma. All right, I'll stop there. This time I've got a few more. Travis.
Yeah, I've got a few.
I'm saying that's very typical that they won't give you a diagnosis on a biopsy for lymphoma.
It's hard to make, especially if you just have I think when they did the VATS, they were just on the edge of it, and then the core get a lot of tissue.
No, we've done like cores on these, and they just never atypical lymphocytes can't exclude lymphoma. I mean, that's basically every time we biopsy something like that.
Do you guys see a radiograph?
We do.
All right. This is a quick one. I think this is entertaining, and Seth and Brand especially will like this because this is the kind of patient population they would see, especially at Grady. This is not outside the patient, and it looks like a needle. They did a neck radiograph too, and you can actually see on the neck radiograph the eye of it, and it's a sewing needle. But I show this for 2 reasons. You have to read this history. So Spanish-speaking male who was at a private party when he drank a murky shot glass of tequila with a cockroach in it. And apparently, I don't know if the needle was in the cockroach or what, but The other reason I show this is that this is just a portion of the operative excerpt, and they spent over an hour trying to find this, including multiple times when they brought the C-arm in for radiograph to look at this thing. So, he swallowed it, and it ended up near his carotid and internal jugular, but it just sounds like it was a disaster in the operating room. But I thought you guys would like that history.
Yeah.
So, and they did confirm it was a sewing needle, as you can see right here.
That's a big cockroach to hide a sewing needle in. My God. Jesus. That's a good.
All right, now.
I wonder what the real story is.
All
right, now I'm gonna get serious here. This is I was working a couple weekends ago or last weekend, and this one came in, and I'll let you look at the radiograph for a second. This is along the airway theme, which is a big clue that Jeff and Howard have already shown. And clue number one, she's got a port, so something's going on with her. But her history is now 2 months of worsening shortness of breath and more recent stridor and wheezing. And you can see looks like there may be something in the distal trachea, because you should see a carina here, and it looks like you get this inferior bulge here. And the port obviously will come into play with this too. And so much like Jeff's case, just in a different location, it looks like the epicenter of this thing is really in the left paratracheal space and probably eroding into the trachea as opposed to starting in the trachea like that squamous cell and working its way out. And you can see how it kind of dips down to the carina, and this corresponds to the finding on the radiograph. She also has this other lymph node and then this huge left supraclavicular node. So she actually has a history of endometrial adenocarcinoma, which I think was all the way back in 2009 or 2011, 7 years ago, and had a pelvic recurrence 2 years ago. And they thought that she was disease-free outside of her pelvis. And so this turned out to be another interesting ordeal in the OR, because they took her to the OR and didn't have the right equipment to actually get past this. They had to fly in some special scope the surgeons could use and bypass this, and they've eventually debrided it. It did turn out to be metastatic endometrial adenocarcinoma, and so I'm assuming it was mediastinal with lymph node involvement. And I found a case that I don't have it on my local machine, but I think Jacobo was the one that showed it 3 or 4 years ago. It was very similar to this, and it turned out it was cervical cancer that had metastasized and invaded the trachea as well. So now we've covered primary lymphoma and metastatic disease of the trachea today. So it's good coincidence, right? This is one of those just cases that is confusing to some degree. So this patient has UIP. Oh no, I don't think I have the complete series here. But anyway, actually I have the important part. So this is one I read back in November of last year, you'll see. And this guy, he has UIP, IPF, he's in his 60s, and he has this what was new at the time, this band of consolidation here in the left upper lobe. And it really is unfortunate. I don't have the rest of the images, but I'll show you the prior study that I was comparing to, or it was, at least at this time, growing. You can see there's a little bit of ground glass there, and something in that area. And when you look back even further, maybe a little bit of ground glass, but not much in the way of soft tissue at all. So I was worried, of course, increased incidence of lung cancer in these patients. And instead of doing a PET, they gave him some antibiotics and some steroids, thinking maybe it could be organized pneumonia or cancer. And then he came back and it was completely unchanged 4 months later or 3 months later. So it kind of grew, and then it looked like it stopped growing. This was May, and it looked stable, if not a little bit decreased. And perhaps the fibrosis is a little worse in that area. And then this was the final study they had, where at this point it was, if anything, looks less than it did a few months ago. Certainly not worse. But he went to a lung transplant last month shortly after this, and sure enough, it ended up being an adenocarcinoma.
I think we've lost you, Travis.
Oh, can you hear me now?
I can hear you.
We can hear you.
Okay. Yeah, so this thing turned out to be an adenocarcinoma. So it kind of grew and then stopped growing and was fairly stable for 8 months before he went to transplant, and they took this out. And of course, these patients, they would have never really considered biopsy, just given his, his degree of fibrosis. But I don't know. I just find it confusing because cancer can kind of do whatever it wants.
So, Travis, did they describe how big the cancer was in the explant? Is it possible that most of what you're seeing is a desmoplastic reaction, or did they give like a 3.7 centimeters? Wow.
Yeah. So it was most of that band, and I think they actually described it as a band-like. Yeah, no, they didn't really describe it that much, but 3.7 centimeters. Yeah, isn't that crazy?
I would have just called that focal fibro. I would have just called that focal fibrosis and just been done with it. I would have never thought that was, even with it changed like that. I would have never thought that was cancer.
Yeah, on this one, I was worried it was cancer, or that it could be, or it was a focus of, infection or something, and then it stabilized or slightly got better, and then we just, I actually read the follow-up and said, I think it's, it's stabilized. It's probably just some focal fibrosis. Yeah, especially because it didn't change, or at least even look like it slightly regressed, but.
And interesting,
just to show.
Travis, the traction bronchiectasis in the lesion seemed to get worse as it seemed to collapse down, which would support it being fibrosis. Yeah. When you had the terminal scan, looks like I saw
this one
were bigger, which looks like
I know. That's why, as my colleague Brett here says, never bet against cancer, but this one we had bet against cancer. Oh right, this one is just bizarre.
Was it a double lung transplant or a single lung?
Double. They took it out.
But the single lung is a good choice.
So this is another radiograph I encountered when I was on call, and it's kind of peculiar because you look at this, and I looked at this, and my first guess was that either this person had had a pull-through and an esophagectomy, or they had achalasia and had just a dilated, fluid-filled, presbyesophagus or achalasia, something. But as you'll see, it gets much more interesting than that. This was 4 days before that. Similar configuration to this big lobulated thing, but it's all full of fluid at that time. And I'll go back in time to 2007. Anybody have any guess as to what this is before I show all of this?
And it's lateral projection?
Yeah, let me. And it certainly is in the region that you would expect esophagus and stomach.
It's like colon.
Is it?
Yeah, or colon, right. She's
like an interposition.
She's never had surgery.
No. Ever have pancreatitis?
No, that's what. Yeah, that's. What'd you say, Jeff?
Ever have pancreatitis?
Never pancreatitis, and that comes into play. And so here, you can see her esophagus. This is in 2007. She had this big multi-lobed cystic lesion, that goes into the upper abdomen, traverses the diaphragm right here, and had never had pancreatitis that she knew of, never had anything. And so at the time, this was thought to just be, there's a peculiar little dot of air right here. But so they thought this was just a massive foregut duplication cyst. I don't know. I don't think I've ever seen one this large traversing the diaphragm, but she comes back. So this was the time of that other radiograph when it was still all fluid-filled. And it's gotten larger, and she came in at this time with chest pain. Of course, she doesn't have a PE, but on this early phase, you may even hallucinate a little bit of wall thickening in this thing, but especially the intra-abdominal compartment component has enlarged. But she had chest pain. I think they gave her antibiotics or something and sent her home, and then she came back that weekend. So this is the CT I saw, and now you can see that this thing is containing an air fluid level. You can definitely see there's enhancement in wall thickening, and there's air throughout it. They'd done a barium swallow. There was no communication before. And not only is there air in it, that it's gotten smaller, that this portion looks like it's decompressed. So regardless of the etiology of the cyst, whatever this thing is, I thought it was probably super infected, but I thought it probably had to have decompressed somewhere, either into the right lower lobe or into the esophagus, given the fact that it had gotten smaller. They took her to surgery, took this thing out. It was infected, but they never actually found a communication with anything. They said that the superior portion of it kind of went into the submucosa of the esophagus, but wasn't communicating with the lesion or the lumen of the esophagus. But they also didn't really ever call it a duplication cyst. They did say it had squamous mucosa, so it could be an esophageal duplication cyst.
Why isn't it just an esophageal duplication cyst that got infected and got a communication?
Yeah,
that's what I think.
Yeah, I think that's what it is. They just never actually called it that.
Oh, okay.
But I was just curious why it would have gotten smaller and gained this big air fluid level without some sort of communication and decompression somewhere. I thought that was kind of curious. Because over 4 days, it
was a communication. They just didn't find it surgically. That there had to have been a communication. And if she didn't vomit a bunch of fluid, she probably swallowed the fluid into her stomach. It probably went out that way.
Yeah, and that's what I kind of thought too. And that's even what I said in my report, that I think there had to have been a communication somewhere, given that it had gotten smaller. And I don't think all of this air is just from a gas-forming organism. I think it's from the communication.
Yeah,
would be my guess.
Yeah,
it's the gas too clean trap. It's not like loculations where you get bubbles. I mean, there's a door to open.
Yeah.
You also wonder if it got infected and that's what opened the communication, or maybe it was like a functional communication as long as it was doing that. Wow, that's impressive.
Yeah.
Oh.
Yeah, I've never seen a duplication cyst that large.
Never.
No. But yeah, Jeff, my first thought when I saw the CT was that she must have had pancreatitis at some point, and that this was a pseudocyst that had tracked up. Because I think even you've shown one of those that was that large.
Yeah, they're huge. I mean, look like a giant empyema almost.
This one doesn't look inflamed around it. The way those are inflammatory, and there's a lot of muck in the mediastinum, and everything looks clean here.
Right.
And the big pancreatic pseudocysts in the mediastinum should not contain air, and unless they get infected or communicate somehow with
So
esophagus.
I don't know. But
Travis, how old is this person?
She's in her 50s, I believe. Let's see. 55. Yeah. So she was in her 40s when this was just apparently discovered incidentally back in 2007. So.
Wow.
I don't know.
All right.
But
it's gone.
I'll leave it there.
All right, guys. It's 3
Exactly.
o'clock here, so we'll call it quits for the week. But thanks, and we'll see you next.
Thanks for the nice cases.
Yeah. All right. Bye, everybody.
Hey guys.
All right.